All right. Okay, now everybody pours in. I love the picture of Teresa versus video Teresa in real life.
You look like you're dreaming.
I probably was.
Staring at your bottle of wine.
Probably. I know I have a green juice, a wine, an energy drink, and a coffee in front of me. That's how this is all going. Hello, everybody. Welcome, everybody. Give a few minutes for everybody to get on. Yay! Hi, Brenda. Thank you for telling me that. Hello, everybody. Yay! Hello, Michelle. Jananne. Hello, Catherine. Oh, you're so welcome, London. Thank you for coming. Hi, Danny. Oh, yay. I love seeing familiar names. Lauren, hi. Yay, everybody. What do you guys all see now? Do you see the Brady Bunch screen? Oh, you just see me. Oh, great. Okay. Oh, wonderful. I'm glad you all see me. Okay. I'm staring at all my friends, but yes. No, we cannot see you. I can just see the other presenters. We have a panel screen up for tonight. So no, you guys are all in webinar mode, so don't worry I cannot see any of you out there watching. Yeah, and yes, everybody is muted. All right, well, we will wait just a few more minutes to get started, but I just wanted to hop on quick. I'm Teresa Richard, coordinator of all this chaos here, but welcome, welcome, welcome everyone for coming. We have an amazing lineup for this summit. I'm so grateful to everybody that is contributing their wonderful brains tonight, and I'm so grateful to all of you guys for showing up and listening. If you have any questions at all throughout all of this, questions how to get CEUs, all that business, please email info@medslpcollective.com. I'm getting tons of private messages. I'm trying to get to them as much as I can, but if you could just email in, that would help us out so much. I think that's it. So thank you so much, everybody, for coming. And Lauren Hermann is our content. Oh my gosh, Lauren, what are you?
The content's
creator. I need more coffee, energy drink, wine all together. Okay.
Not
Anyways, Lauren Hermann will be your host for tonight, and she's presenting. And we have all these wonderful presenters as well. So thank you guys all so much, and I will let you all take it away.
All right. Thank you so much, Teresa. And welcome, everyone. We are so excited to kick off another round of the MedSLP Summit. So let's go ahead and just dive right in. We are going to go ahead and get started with our first presenter, who is Tiffani Wallace, and she is going to talk all about home exercises and home health. So for all my home health SLPs out there, special shout out to you. And Tiffani, I'm going to let you take over.
Okay, I'm going to go ahead and share my screen. And this can actually, I work in home health, so that's my application, but this can really be for any setting. So just talking about putting the patient to work. Therapy doesn't always work unless we actually make the patient responsible. So the financial disclosures, I am the co-author of the app Dysphagia to Go, and I screen aphasia through Smarty Ears. I'm the co-author of the app Dysphagia Therapy from Tactus Therapy. I've presented webinars for PESI, Northern Speech Services, speechpathology.com. I'm also the co-author of the Adult Dysphagia Pocket Guide, and I'm the owner and endoscopist at Hoosier Mobile Dysphagia Solutions in Indiana. I am the administrator and creator of the Dysphagia Squad on Facebook, which I get zero money from that. And then I also write Dysphagia Ramblings. So I'm going to get started because we have very little time when we get going. A home exercise program is actually a great way to keep your patient working through the week when you're not able to be there. I know a lot of times in outpatient, you maybe see the patient 1 or 2 times a week. In the nursing home, you see them every day. In home health, and especially since PDGM has hit, I usually only get 1 time a week. And so that's not going to get anybody anywhere very fast. So I always have a home exercise program no matter what the person's goals may be. So what does a home exercise program look like? And it can be used for any area of speech, cognition, if the person has dysarthria, apraxia of speech, aphasia, dysphagia. It gives the patient a chance to actually practice those strategies or the skills that you have been teaching and cueing in your session. It should actually enhance and not hinder patient progress in therapy. And so when we're talking about hindering progress, if the home exercise program is too long, it takes too much time, it's too many exercises, it's too difficult, it's something that the patient doesn't understand, they're not going to do it. We should be giving them opportunities to practice what they've learned. We should be giving them opportunities to be successful. We can also teach caregivers, spouses, family members, whoever is with that patient, caregivers. We should be teaching them the same strategies that we're using, the same cues that we're using when we have that opportunity, so that they can cue that person anytime they're practicing. But I always make sure too, if the person that's working on the home exercise program, if that's a spouse, if it's a family member, a caregiver, to not cue them every minute of every day, because that's going to get very, very frustrating for the patient. So maybe have set times that they're actually using the cues, they're actually working with the patient, and then give them a chance to just be themselves and to do what they're doing without somebody constantly cueing them. A home exercise program should not be too much for the patient. If we're giving them 500 exercises that maybe we've taught them 200 of them, it's way too much for the patient. If it's too difficult for the patient to complete, if the exercises are just something that they're not able to do in therapy. So for me, for a lot of patients, it's trying to teach maybe the Mendelssohn or the supraglottic swallow with my dysphagia patients, and they're just not getting it through therapy. If they're not getting it in therapy, don't make that part of the home exercise program. I've had so many patients, and working in the home has been really, really nice because I can actually see these people, I can see their home exercise programs, and I can see where they're digging their home exercise program out to show me. And so if it has a 5-inch layer of dust on it, I know that they're probably not doing it, and that happens frequently. There's actually a research article from Purdue. It's the I Eat lab with Georgia Malandrecki. And she started talking about the dysphagia, I think it's the intensive dysphagia rehab approach, it's IDR, where you're only teaching the patient 2 exercises at a time. So they may be doing, say, the Mendelssohn maneuver and the effortful swallow. So one day they're doing the Mendelssohn maneuver, the next day they do the effortful swallow, and they just switch back and forth. So they're not doing 2 exercises every day, and they're only doing 1 exercise every day. And they're a lot more compliant with that, which I think I would be too. If I had to have a long list of exercises, I would not be doing them. So one downfall of a home exercise program is that when you give a home exercise program without services, you can assist the patient in advancing the home exercise program. So you're not progressing the exercises or the complexity of tasks. And this is one thing that we see a lot of times in home health, and especially when we start having limited visits that are approved through insurance, that maybe the patient only gives you so many, is that you can't actually progress those exercises. You can't increase the level of difficulty. You can't add resistance if you're working with swallowing. If you're working with cognition, you can't start taking away cues and start adding more independence. You can't change anything if you're only giving them a home exercise program. So when we talk about home exercise programs and we're talking about cognition, even in just doing therapy, I hate doing worksheets. I hate them. My patients hate them. I don't even try to pull them out. So I'm not leaving a big stack of worksheets for the patients. What we're doing is I may have one of their exercises for the week be that they identify areas that they were doing independently before and now they're needing help with. So that may be finances. It may be they were independent with their medication management. They were independent with their shopping. They were able to use their calendar or use a planner or any of those types of things in their home without any help. And now they're not able to do that. So we may come up with some memory strategies in the home. For a lot of patients that have trouble with orientation, we've been getting, it's a digital frame that has the day, the date, the time that changes automatically, so they don't have to change anything. It's always displayed in a large display that shows the person what the date is, what the day of the week is, what the time is, so that they can start looking at that to help improve their orientation. We may practice tasks such as filling their medication box. And the good thing with home health is a lot of times we can actually help them fill their medication box. We don't have to do anything that's pretend. A lot of times for patients also, it may be that we are identifying that they're not able to do this on their own. So a lot of patients are starting to go with more automatic medication boxes so that they may open up at a certain day or time, and the person only takes that pills. That's the only pills that they have access to. And so you can work with ways to help them remember to set the box in a certain spot, to sometimes the box has an alarm, sometimes it doesn't, but just to help them identify what that alarm means, that, oh, it's almost time for my pills to come out. So you can work with different ways with that. You can work, sometimes I get, there at the Dollar General store, you can get eight packages for like $2, but they almost look like little capsules. And if you put them in water, the outside part dissolves, and it's a sponge inside, but there's like 4 different colors. And so you can put those in empty pill bottles by color and have the patient actually fill a box according to instructions. And then that way it's a little more like their own pills, or they actually kind of look like real pills. You can work with paying bills. You can work with them making a schedule, making reminders on when their bills are due. You can work with them on writing checks, on practicing doing their checkbook ledger, which that's not something that I do because I do everything online, but most of my patients still pay their bills using checks. They still like to balance their checkbook, which for me, I just check my balance, but most of my patients do not do that. You can also work on tasks such as sequencing, so cooking, making coffee, putting away the dishes, loading the dishwasher, brushing their teeth, their routine in their shower, getting out of the chair safely, using their walker. So all of these different things, you can work with that patient. You can have the family members use your same cueing. You can write down the steps, make maybe index cards so that the person can actually see the steps, 1, 2, 3, 4, 5, however many it is. And then the family can actually work on that skill with that patient, because maybe making coffee is very rewarding for that patient. They like to make their own coffee. It's something that they can actually do. And so that gives them the reward at the end, is that they actually have their cup of coffee. When we talk about aphasia, a lot of times I would kind of look at aphasia or apraxia almost together. Just because you're working on that speech, you can do the same types of activities for patients. You can build a home LARC box with important items for the patient. So if they have a favorite tube of chapstick, their Kleenex box, their favorite coffee mug, their glasses, their remote control, some of those things that are a little more important to the patient, you can actually use those items to work on naming. You can work on the cueing techniques. If the person has aphasia, you can work on cueing if the person has apraxia. But if we make the items more meaningful than like the actual LARC box, it's going to be more motivating for that patient. So always have them practice words that are meaningful. You might even find words that the person talked about a lot before. You know, maybe they're a baseball fan and they really were into baseball. They had a certain team that they liked. You can go through and you can name players, positions, the colors of the team, different sayings that happen at a baseball game, but just make it meaningful to that patient. And that's going to be so much easier for that patient to actually work with you than if it's just a bunch of random meaningless words. You can increase then. You can use your words. They can be put into phrases. They can be put into sentences, reading, conversation. So you can do a lot with the same activity. You can have the caregivers work even with the patient to come up with phrases, sentences that are important to them. So you always want to make it as important to them as possible, and you're going to have a lot more carryover. Teach the caregivers the strategies. So if you have a patient with apraxia, I have one right now that we're working really hard on getting him to a point that he can say the words without as many cues. And one thing that helps him is if I just mouth the beginning sound of the word. And so if I just put my mouth, if he's saying mom, and I just do the for mom, that cues him to say the word. And so I teach his significant other, I teach his son, his daughter, even his grandkids are great in helping him with these different cues. And so you can teach that so that it carries over across different settings, across different times in that patient's day, and really start to work on a more functional approach for that patient. For receptive aphasia, when you have a success with the patient at a level, especially those lower level patients that sometimes we're working on yes and no, or we're working on something simple, wait until they're a little bit more successful with you to have them practice with the family and caregivers. And this is just something that I've found that works best for them. You have less frustration on the caregiver's part, less frustration on the patient's part, but give them yes and no questions related to their personal information. So I always work on personal information. Is your name George? Is your name Sam? And when they can get pretty consistent with that, you can continue from there. Do you live in Indianapolis? Do you live in Atlanta? So make it something that they know, and then you can branch out. Following directions related to tasks that the patient needs to complete daily. So they can work on following directions to brush their teeth, to go fix their cup of coffee, to put the sugar in. Oh, nope, you usually only use 1 teaspoon. You can work on the written directions. You can have the person following those different tasks. Anything that's going to really bring in that salience of the activity is so much better for the patients. With dysarthria, have a list of words that the patient uses, their strategies to say daily. So words that are meaningful to the patient. And I always ask patients, what are some things that you talk about every day? And it may be that they talk about their walker. They talk about, where are my glasses? They ask what's for dinner. They need to have assistance to go to the bathroom. So they ask for assistance to go to the bathroom. And you can break that down to just a single word. And then again, you can use those same words that they've come up with and use them in a phrase, use them in a sentence. You can have the patient make up their own sentences when they get to that level that they're able to do that. They can read from a favorite book, newspaper, or magazine. So it doesn't have to always be something that you bring it into the home or that you bring to the outpatient therapy clinic. You can actually have the patient, the family member, the caregivers, if they're coming to you, you can have them bring some of these things that are important to the patient with them that will come and you'll work on it during therapy and it goes right back home with them. So you don't always have to come up with your own materials. You can actually use what's in the patient's environment. With me working in home health, that's been easy. It makes it easier for me because I don't have to lug all that stuff in every single day, every single house. I don't have to fill up my trunk with a million different materials. I use what's available for me in the patient's home. When we come up with words, sentences, I use a piece of notebook paper and a Sharpie and I just write them down. So you can also dysarthria work at the conversation level, and patients love to talk to you. So you can even structure it, we're going to talk about your granddaughter today. I want you to tell me all the things about your granddaughter. And it gives them something that they enjoy, something that they can do with you. If you're working on voice, you can have the patient work on achieving their optimal voice in therapy. Once they reach that, have them continue to practice what they've been doing in therapy. So if you're working on different vocalization techniques, if you're working on straw phonation, I don't get a lot of voice, so I'm probably not the best at voice. I know we've got a good voice talk coming up here soon, so maybe you can learn some new techniques from that. But any of those things that you're working on in therapy, the person starts to get it, starts to understand what they're doing, have them continue that as their home exercise program. That's the most functional way to do this, not giving them a stack of worksheets that have nothing to do with what you've done in therapy. With dysphagia, you can give the patient a list of exercises to work on when you are not with them. So you may give them, say you're giving them the 2 exercises, you give them the Mendelssohn maneuver, you give them the supraglottic swallow. That's what they do when you're not with them. You don't have to sit there and watch that person do those exercises every day. That's not necessarily your therapy. Your therapy may be to see them do the exercises a couple of times, and maybe you need to make some adjustments. Maybe you need to tell them, okay, when you do this exercise, I need you to do it this way, not this way. Or, okay, now we're going to add this to the exercise just to make it a little more difficult. So a lot of times we're seeing people given a list of exercises to do for their swallowing, but that's the same thing that they do every single day in therapy with you. So while they're working on those exercises at home, you can continue to work with them when they're in therapy with you on their swallowing goals. You can use food. You can have them continue to use their strategies and exercises on their own. But for you, you want to actually get them to a point that they're able to upgrade their diet. They're able to swallow without choking, whatever their goal may be. This is a part of, if you do MDTP, the McNeil Dysphagia Therapy Program, is once you get them to a certain level in the stages of that program, then they continue that program daily as exercise, as a home exercise program. So that's what we need to do, is get the person doing what we're already doing with them. So if they are taking bites of applesauce and they're working on using an effortful swallow, and they're able to swallow that applesauce, that bite of applesauce, say 8 times out of 11 trials, then let them continue to do that as an exercise, especially if they're NPO. We want them swallowing as much as possible. As you upgrade the person, when they're ready, upgrade to the next level using their strategies. Oral care can be included in their home exercise program. I will often tell them, I want you to brush your teeth. This is how I want you to do it. I want you to do it before you eat. I always do before you eat breakfast, lunch, and dinner, because I want your mouth to be as clean as possible. That way, if something does go down the wrong way, there's less chance that they're actually aspirating, or there's less chance for aspiration pneumonia. So I went through that very, very, very quickly. I'm going to stop share on this.
We do have a question that came in the Q&A for you. So let's see, we have someone that said, any tips or insight regarding working on online banking with patients while also maintaining their privacy, i.e. not being able to see their account balances, etc.?
Usually what I will do is I will, I'll ask them, you know, do you want to work on this with me? If they don't, and we're working on that, I may just kind of try to recreate what it would look like on a piece of paper. And then maybe we log into the bank account, but we're not looking at any of the information. And we're just writing down the steps to get into the banking account. So maybe, you know, it's okay, go to this website. You need to type your username here, type your password here, and just kind of give them the steps to do it without actually getting all the information that you need. If that makes sense?
Okay, thank you. And we got another question that came in just now. Do you have them brush before they eat, not after?
I do have them brush before they eat, because I feel like if we wait till after, when they're eating is when they're going to have that highest risk, you know, that they're probably aspirating something, you know, or that you are when you're swallowing something. So I always do it before so that their mouth is as clean as it can possibly be.
Perfect. Okay, got another question here. How often do you recommend patients purchase apps to include in their HEP?
For my patients, I think I have two right now that are in their 30s. So I do have one of them that uses different apps. We set up reminders. I try not to make them purchase apps. So it's not necessarily a speech therapy app. It's maybe that we're using the reminders app that is included with any of the iPhones, if that's what they have. A lot of times there will be a notes app that they can go in and they can write down things that they need to remember. Using their calendar app is huge. We use a lot of setting alarms and naming the alarm. One has an alarm set for when I'm coming. And so, you know, when it goes off, instead of just saying alarm, it says speech therapy. So I try to use it very functionally when we're doing anything digital, but I try not to make it so that they have to purchase, because that can be very, very stressful for a lot of people, especially for me. If I'm seeing them, they're not working because they have to be homebound.
Okay, perfect. Let's see here. Do we have any tips or experiences with working with acute rehab SLPs in terms of handing off patient care and HEP that was developed in ARU?
I think a lot of times what I see is that those HEPs come home with the patient. So, you know, they may travel. And so one thing that I do also, and this has come up a lot, is when you get a patient that has an HEP that is maybe not the best evidence-based HEP. So it's exercises that maybe we know aren't very effective for what is going on with this patient. And so I'll just tell that patient that, you know, you've been doing these exercises for a while. It's time that we kind of revamp them and do something a little bit different. So you can go off of what they've already been doing, but a lot of times I change it because they may not be making as much progress as they need to be. They may be doing some exercises. We may cut out exercises and make it so that it's not quite as many. So, but yeah, I think I think the best thing to do is to create a network in your area as much as you possibly can, so that you can talk to the SLP that is before you and that you can share the information, you can send it down, you can, tell them everything that they need to know.
Wonderful, thank you. I know we still have a couple more minutes, so I'm gonna keep going through these questions.
I was trying to read some of them also. The digital frame that we use, I've seen several of them, most of them from Amazon. I think you can get them at Walmart also. I have seen them on the Walmart app. So they are out there. They're anywhere between $30 and $60 that I've seen, but they're so great for the patients.
Awesome. And I see here, someone's asking you to please repeat the information regarding the fake pills that you spoke about getting at the dollar store.
Yeah, those fake pills, they're in the toy section, and they're just the little, you'll see I think there's red, green, blue, and yellow. And once you put them in water and soak them, then a sponge comes out, and it might be a dinosaur or a smiley face. But those are great because they're not actually handling pills if nobody is really confident with them having their real pills. So I use those sometimes too. And that way it just kind of simulates a pill. It looks more like a real pill. And, you're there so that they don't try to take those pills, which I'm thinking if they're trying to take those pills, that doing the medication management may be a little high level for them.
Okay, wonderful. And we'll just do one more question here. Any advice on patients who are rushing to go back to work after hospitalization and short recovery home, specifically in terms of family expectations and fatigue, so patient with apraxia or aphasia?
Sure. So what I do is I try to find out as much as I can about their job. Okay, what do you have to do? What are the expectations at your job? And we'll try to simulate some of those expectations. So we might sit there, and if they're working on a computer, if they're working with numbers, we might get out their computer and just have them do certain things on that for so long. And a lot of times what happens is that you, when you're going through this and they're doing the simulation, they start to realize how tough it is on them, and they start to realize how tired they're getting. So a lot of times, I'll work with them also and say, okay, work with your place of employment and see if you can maybe start out only 2 or 3 hours a day and then gradually work up. And a lot of times that helps that person, because with the aphasia and the apraxia, some of them can go back to work without being able to talk because maybe their job doesn't require that they speak, and they can do everything else they need. And that's fine. So it has to be a lot what the patient's comfortable with, what the patient's able to do. And for me, most of the time, they realize they're not ready.
Okay. Thank you so much for all of this brilliant information. I saw a lot of great questions and a lot of really supportive comments too here. So everyone really seems like they've enjoyed what you've had to offer, Tiffani. Thank you so much.
You're welcome. Thank you guys for being here.
All right, I am gonna just go ahead and share my screen, and I'm gonna keep my camera off just because I don't like having my camera cover up part of my slides. So I'm gonna keep this up. So my name is Lauren Hermann. We're just gonna dive right into the next round of presentations here, which is mine, titled The Heart of Speech Pathology, Cardiothoracic Considerations. So a few disclosures, I do receive financial compensation through the MedSLP Collective for this presentation, and I'm also employed through the MedSLP Collective. There are no non-financial disclosures that I have relevant to this topic. And just a quick little tidbit about me. I've been practicing since 2012. I've had experience across the skilled nursing facility, acute care, inpatient rehab, outpatient rehab, private practice. I am the content director for the MedSLP Collective. Currently see my own patients through my private practice. And just a quick little fun note, I did just publish a book about our profession titled, But My Speech is Fine. So let's dive right into the heart stuff. First things first, anatomy. So the pericardium, you might see mention of pericardium in imaging notes here. The pericardium is the membranous sac that encases the heart. But if we look beneath the pericardium, you'll see here that we have the right atrium and left atrium, which are just chambers of the heart that receive oxygenated blood, and they pump it into the ventricles. The ventricles are the chambers of the heart that receive oxygen-rich blood from the atrium, and then they pump blood away from the hearts. And then the aorta is just the blood vessel system that is part of a closed circuit between the heart and the lungs. So the pulmonary artery actually branches into the lungs, and it further subdivides into smaller branches. This is where deoxygenated blood is carried from the heart into the lungs and the tissues through pulmonary arteries. Then you'll see the pulmonary veins, which is another blood vessel system that's just part of another closed circuit between the heart and the lungs. And the pulmonary veins originate in each lobe of the lung and open into the left atrium of the heart. So oxygenated blood is carried to the heart within the pulmonary veins. And then you'll see all of these valves. So you'll see the pulmonary valve, the aortic valve, and the tricuspid valve and bicuspid, or the mitral valve. And these valves, they're basically just, I like to call them flaps, and they protect backflow of blood going from one chamber the wrong way up into another chamber. And then you have the vena cava. You've got the superior vena cava and the inferior vena cava. The superior vena cava, these are veins that bring blood to the heart. So the superior vena cava brings blood from the superior portion of the body, and then the inferior vena cava drains blood from the inferior portion of the body. So moving on here. So again, continuing to look at anatomy, this is just pretty important for basics, especially for SLPs, because there are two major considerations. You can see the heart here, but directly behind the heart is the esophagus. And then you have the recurrent laryngeal nerve that wraps around the aorta here. And this can cause some serious issues with swallowing and voice. There are two major pieces of anatomy that can just directly impact these domains of our field. So it's really important that we do understand the anatomy and any disease process or injury that could impact these structures. All right, so the domains of speech language pathology that could be impacted by the heart, really it's all the domains, but you will see more research focusing on voice, swallow, and cognition. And of course, communication can be impacted. It can really affect just the entire system, but you'll see more research on these three particular topics. So with this presentation, because we only have 30 minutes, I just have time to really focus on the swallow. So that is what we will look at. Now, starting with considerations with dysphagia in the heart, we are going to be looking at disease, anatomy, and surgery. So just trying to keep things a little bit simple here by breaking it down into these three subcategories. So let's start with dysphagia and heart disease. Cardiovascular disease is actually the leading cause of death, accounting for an estimated 31% of deaths worldwide. And this is from the World Health Organization 2021 statistics. The reported incidence of dysphagia in this population varies anywhere from 2.7 to 51%. And a lot of studies have focused on post-operative dysphagia. However, a more recent study from 2020 looked at individuals with cardiovascular disease who were admitted to a hospital, and this study found that 46% of these patients presented with some degree of swallowing impairment, which is pretty huge. This is really important to consider when you have these patients that come in with cardiovascular disease. Now, when we're looking at common cardiovascular disease that we may encounter, so you might see CAD in many of your patients' past medical history. That is coronary artery disease. This is actually the most common heart disease in the US, and it can lead to a myocardial infarct or a heart attack. Also, congestive or chronic heart failure is really common. And then stroke is an extremely common result of cardiovascular disease. So you might see a lot of these diagnoses with your patient population here. Now, looking at risk factors for dysphagia in adults with cardiovascular disease, we have stroke, malnutrition, prolonged oral tracheal intubation, and age over 80 years. So when we're working with a patient with a history of cardiovascular disease, we just have to consider a lot of factors, but these so far are some of the more common factors to consider according to Almeida and colleagues. Now, this doesn't mean, of course, that if you have a patient with cardiovascular disease who is under 80 or has not recently been extubated, or is well nourished with no history of stroke, it doesn't mean that someone who doesn't match this has absolutely no risk factor for dysphagia. We do have to take the entire story into consideration, but knowing these things that are recognized risk factors should assist you and your assessment and your recommendation process, especially if you need to justify getting an instrumental swallow study, which I know many SLPs unfortunately do have to fight for that. Okay, so how can a weak heart lead to dysphagia? There are a lot of reasons. So according to this study, and I know this is a bit older here, so in 2001, these authors discussed how arterial blood pressure and cardiac output, they're often reduced in patients with chronic heart failure, which this can lead to reduced cerebral blood flow and neurological symptoms, which many of us know with neurological symptoms can also come with swallowing impairments. The heart, or part of the heart, can actually enlarge as it overcompensates. If it's really having to pump extra hard, it can actually enlarge, and this can lead to a mechanical dysphagia, which I will be going more into detail with mechanical dysphasias soon. Fluid can collect in the lungs, and this can lead to shortness of breath, rapid fatigue, and left atrium dilation, which can actually compress the esophagus. And again, I will be going more into that as that's more of a mechanical dysphagia. All right, so with medications, there are a lot of considerations with medications. And again, since this is such a short discussion, I can only break it down into two categories here. So dry mouth, tons of medications can cause dry mouth. But when it comes to our cardiac patients, things to be aware of would include ACE inhibitors, which these are used for high blood pressure. Here's just a list of maybe some of the more common ACE inhibitors that you will find that your patients might be on. And also heads up with lisinopril, this can actually cause coughing, dry coughing too. So check to see if your patient is on lisinopril if you do see a lot of coughing. Antiarrhythmics. So here is just a short list of the more common ones you might see. So Norpace, Mexatil, and Procan. Diuretics to get rid of that excess fluid. So you might see Itacrine, and then calcium channel blockers. So this is for chronic chest pain due to angina, and you might see Norvasc. I feel like I've had a lot of patients in the past with Norvasc. So these medications, and again, there are plenty of others, but these are really common with causing dry mouth. So just be aware of this when you do see your patients who might be complaining of that, which can impact, of course, their oral phase of swallowing, if it's really difficult to moisten everything up, and the oral hygiene. We just want to make sure we can help them continue to keep a moist oral environment. And then looking at esophageal injury, this is something else to consider with some cardiac medications. So looking at potassium chloride supplements, those potassium pills, they can be pretty big. So you might see K-DIRT, K-TAB, Florcon, or Slow-K. So if your patient is on a potassium supplement, these are 4 common ones you might see them on. And aspirin, so Bayer, aspirin, and generic brands. So this can happen when not enough fluid is taken with meds or shortly after the patient reclines, particularly if there are esophageal motility issues. Esophageal irritation or injury can occur when the medications remain in the esophagus for too long, and this could potentially cause damage and affect the swallow. So just a quick little bit that I wanted to touch on with medications. I could go deeper into that with more time. All right, so that is dysphagia related to disease. Let's move on to dysphagia related to heart anatomy. I find this so fascinating. And I remember the first time when I really first learned about this, how heart anatomy alone can actually cause a dysphagia. So the 3 types that I will be talking about tonight are cardiac dysphagia, dysphagia lusoria, and dysphagia aortica. So starting with cardiac dysphagia, another name for this is dysphagia megalotrensis, and this is a mechanical dysphagia caused by esophageal compression from an enlarged left atrium. So that's something that I had mentioned in an earlier slide. And of course, I can't discuss this without showing you guys any images. So here is some radiographic image, or an image here, which shows the left atrium that has been enlarged. And you can see how that is just compressing against the esophagus. and what this looks like on a barium esophagram. So it can impact the motility or just having the fluids or solids move downward into the stomach if you have that extrinsic compression. So symptoms of this type of dysphagia, typically you'll see dysphagia for solids, weight loss in more severe cases, cardiomegaly or enlarged hearts, and congestive heart failure. And the most serious complications would be an atrioesophageal fistula, and this can result in fatal vomiting of blood. Treatment options for this, you'll see this pretty much with any of these mechanical cardiac dysphasias here, it's based on heart anatomy. Treatment is necessarily really only if it's symptomatic. People can go their whole lives not noticing any symptoms. Typically, it'll be dietary and compensatory strategies that will be effective in these mild cases, and surgical intervention may be recommended in the moderate to severe cases if they are a candidate. So pulling up a case study, these are case studies that have been published. This is from 2020, found in an article titled Dysphagia as an Early Sign of Cardiac Decompensation in the Elderly, a case report. So this one looks at a 76-year-old male who was admitted for prolonged dysphagia with solids, which had progressed to liquids. His past medical history, you're going to see a lot of cardiac stuff. So ischemic dilated cardiomyopathy with reduced ejection fraction and coronary artery disease, with left anterior descending artery angioplasty, and he did have prior hospitalizations for volume overload. So remember earlier, I mentioned about the fluid buildup or volume overload, and then CAD being the most common cardiac disease that we might encounter. So an EGD was performed, and real quick, an EGD, just a side note, this is an oh my gosh, I always have a hard time saying this, esophagogastroduodenoscopy, or upper GI endoscopy, we'll just say that. And this is an assessment of the esophageal tissue and structure through an endoscope, which captures video images of just the inside of the esophagus. And again, I'll be going more into this as well as what a TEE is later in the discussion. But he had an EGD performed, which was normal, and this TEE showed an enlarged left atrium. The chest X-ray showed cardiomegaly, and the chest CT revealed a giant left atrium displacing posteriorly the middle esophageal portion with signs of external compression. His report is that his dysphagia is almost always followed by shortness of breath or dyspnea, and both his shortness of breath and his dysphagia resolved after he took diuretics. So this is important to note. Here is the imaging. So check that out. You can see how the left atrium here is pressing against the esophagus. So there's narrowing of the esophagus because of this enlarged the left atrium. Recommendations. So they took a conservative approach, and it actually worked really well. They told him to increase his diuretic dose when his symptoms of dysphagia appeared. Simple enough. So as soon as he started to notice these symptoms with his shortness of breath, he increased the diuretic dose, and voila, it really helped him. So this is kind of one of those easy peasy cases where it's a really good outcome. So I wanted to start out with the good case. So he reported success with this method, and he managed his dysphagia. This one is, I don't know, it's my favorite. It's just so interesting, and I've only seen one case of this. It is rare. So it's dysphagia lusoria. Again, a rare mechanical dysphagia caused by a rogue right subclavian artery that courses behind the esophagus. And this causes extrinsic compression of the esophagus. It's an embryologic abnormality of the aortic arch. Many people can actually live their whole lives without even having any symptoms. And although it is rare, it is the most common congenital anomaly of the aortic arch. And this is just an interesting history of it. It was first discovered in 1794, and it was originally described as dysphagia by freak of nature by Dr. Bayford in 1794. So this is just an example of what the typically developed aorta and the right subclavian artery looks like. But over here, the right subclavian artery, instead of branching off of the right common carotid artery, it is originating over here on the left side, and it's trying to go right. So it courses behind the esophagus, and it can really squeeze up against that esophagus. Symptoms will be dysphagia for solids and pill-induced esophagitis, secondary to that extrinsic compression of the subclavian artery, chest pain, and Horner syndrome. The diagnostic tests that will be used for this is a barium esophagram, a GI endoscopic evaluation, and CT or magnetic resonance angiography with Doppler ultrasounds. Manometry, this is a common test that can show whether your esophagus is working properly by measuring contractions, force of pressure, and coordination of esophageal muscles as the food moves down into your stomach. So this might be a common recommendation when there's an esophageal component. However, in the case of dysphagia lusoria, if there's any concern for that, it's not recommended because they're just non-specific in the setting of dysphagia lusoria. So treatment options, you're going to see this with all of these mechanical dysphasias. It depends on the severity of the symptoms. Usually lifestyle and dietary changes with the compensatory strategies like alternating solids and liquids. Those are considered for the mild to moderate. And then of course, surgical correction can be considered for the severe cases when all other therapeutic attempts fail. So this is the personal case study, the one case that I recall. This is from 2013 when I first learned about it. I did not have this patient, a colleague of mine did. And this was a woman in her 20s who presented with dysphagia to solids and chest pain during meals. Her past medical history was unremarkable. The SLP completed her MBS and she noticed an indentation in the upper esophagus during AP view and esophageal sweep. So this was great because the radiologist was totally on board with the AP view and esophageal sweep. Not all of us are quite so lucky, but it's wonderful that this radiologist did. Solids appeared to remain in this area or slowly pass with a liquid wash. So what ended up happening was the SLP referred the patient to GI, and ultimately with further imaging, like the test I listed above, dysphagia lusoria was confirmed. So here's just an image example that I pulled from a 2020 study so you can see an example. I do look up dysphagia lusoria in the images and you'll see a bunch of different images, but this was the clearest one that I could show. So this is similar to what the SLP and the radiologist saw in AP view. Recommendations in this case, ultimately, it was just dietary modifications. So softer food, smaller portions, alternating solids and liquids. Her symptoms were not severe enough for surgical remediation. She had no weight loss. Her symptoms were mild to moderate, and it really only worsened with larger meals. So she just modified her diet. Okay, so the last mechanical dysphagia that we're going to be going over is dysphagia aortica. So another mechanical dysphagia caused by an enlarged, tortuous, or aneurysmal aorta, or an aortic aneurysm that compresses onto the distal esophagus. So I wanted to pull up several images here so you can see kind of a variety of ways of what this might look like when we're looking at dysphagia aortica. Common symptoms, a lot of these are going to be pretty similar to each other. So progressive dysphagia for solids. Solids are typically the first type of food that or PO, I guess, that individuals will notice dysphagia symptoms to. And this can even include retention of the bolus in the esophagus. Eventual dysphagia to liquids, chest pain, weight loss, abdominal fullness, and nausea. The treatment options for this, again, depends on the severity of the symptoms. So same thing, diet, lifestyle modifications for those mild cases, and then surgical intervention. So here's just a quick little list of some types of surgery that might be recommended. When surgery is not an option and it's pretty severe, then you might be looking at PEG tube or an esophageal stent or dilatation for palliative measures for these individuals. And here's a quick case study. This is dysphagia in the aging cardiovascular patient published in 2017. And they looked at a case study that involved an 82-year-old male with chronic episodes of dysphagia to solids that had progressively worsened to liquids. He had associated unintentional weight loss over 7 months, a lot of malaise and lethargy, and he endorsed regurgitation, halitosis, and intermittent nausea. His past medical history, you can already see some cardiac stuff here. So ischemic cardiomyopathy, chronic AFib, hypertension, hyperlipidemia, chronic renal failure. He had a prior CVA or prior stroke and a previous open repair of an infrarenal abdominal aortic aneurysm. So poor guy had a lot going on. His blood analysis was consistent with malnutrition and he had a high white blood count. Physical examination identified that he was cachectic, or there was muscle temporal wasting, just very feeble looking male with irregular heart sounds. Here is his esophagram and what they described as bird beaking. So there was the extrinsic compression of the aorta, so in that distal esophagus, and you can really see just how compressed this is. So it had a huge impact on his swallowing. So for him, the outcome, he was not a candidate for aortic repair because of his multiple comorbidities and his significant malnutrition. So he did end up receiving a PEG tube and palliative services. So looking at the final piece to SLPs and cardiothoracic considerations with dysphagia, we're going to look at cardiothoracic surgery. Here is just a brief overview of dysphagia risk factors post cardiothoracic surgery. You'll have patient characteristics, associated with the presence of dysphagia following this type of surgery may include advanced age, preoperative congestive heart failure, diabetes, intraoperative use of the transesophageal echocardiography or TEE, prolonged intubation, so greater than 72 hours, an endotracheal tube size of 8 or greater, and less commonly, but often overlooked, you might see vocal fold paralysis secondary to some nerve damage. So here is a new study. I'm going to give a big old shout out to Lexi Myers because she just posted this on her Instagram account, SLP Lexi, and this is great. This is a new study, just came out this year, titled Dysphagia After Cardiac Surgery, Prevalence, Risk Factors, and Associated Outcomes. So what this study found was they did a prospective study to look at prevalence of dysphagia in adults post-cardiac surgery using instrumentals to confirm. And they found that 6% of participants had a quote unquote safe swallow with a PA score of 1 to 2, and only 48% demonstrated efficient swallowing. So being able to clear the pharyngeal residue. The takeaway from this study was that there's a significant association found between aspiration status and pneumonia, reintubation, and 90-day mortality. Those who aspirated ended up waiting 43% longer for an oral diet, an additional 104 hours in the ICU, and 6 additional days in the hospital. Not to mention the cost. So this is always a big thing to bring home if you have to advocate for your patients. This study found that there was an additional $49,372 in hospital costs. So please look up this article. This is an awesome one, and even I need to dig more into this. This is so new. So thank you, Lexi, for bringing that up and posting about that. All right, so why SLP should be a common referral source post-cardiac surgery. Patients with dysphagia post-cardiac surgery, they have that increased likelihood of silent aspiration, are more likely to develop pneumonia, and as we just discussed in the earlier slide, are more likely to have a prolonged stay and increased hospital costs. Dysphagia and silent aspiration, as we know, they're associated with poor outcomes, but especially with post-cardiac surgery. And cardiac surgery is associated with longer intubation times, and as the newer study said intubation greater than 72 hours, this study said even 48 hours in cardiac surgery patients has been found to be a strong risk factor for dysphagia. So we might be able to guide faster treatment options in cases of vocal fold paralysis, but also just looking at dysphagia, we can really help to move the case along in a healthier direction. Speaking of nerve damage, surgery from the left side is more commonly associated with risk of vocal fold paralysis and dysphagia due to that incomplete airway protection, because that recurrent laryngeal nerve loops around the aortic arch. So surgery from the left side does increase that risk. So I would always look at the surgery notes whenever I had a patient who had some type of cardiothoracic surgery to see which side they were coming into, that they operated from. It was left side, and my patient had stridor, hoarseness, breathy or weak voice. I would look to see, did they go in on the left side? Maybe this is something to consider. Severe cases can result in aspiration and respiratory distress. Symptoms can last anywhere from 1 to 2 days in mild cases to several weeks in more severe cases. The treatment options in the severe cases, if spontaneous recovery fails, then you're looking at maybe vocal cord medialization or thyroplasty. For bilateral vocal fold paralysis, lateralization procedures such as laser arytenoidectomy can be considered. Now, I wanted to talk about TEE. I know I'm running out of time here, so I'm going to try to speed up. Per this study with Russo and colleagues, the mechanisms of dysphagia that could result from TEE use remain unclear. We can only hypothesize that trauma during its insertion or use and or compression of pharyngoesophageal tissues between the TEE probe and the endotracheal tube may contribute to this complication. Now, TEE, this is a procedure that creates a picture of the patient's hearts using sound waves. The echo transducer that produces the sound waves for TEE is attached to the thin tube that passes through the mouth and down into the esophagus, down to the throat, into the esophagus. And TEE may be an independent risk factor for dysphagia post-cardiac surgery. And here's just another picture so you can really see there's a TEE tube plus the endotracheal tube. A lot is going on here, so some damage could be continued here. So TE continued, insertion and manipulation of the probe can result in trauma, leading to oral pharyngeal or esophageal dysphagia, and then odynophagia, so painful swallowing is another consideration post-TEE. So overall, do not overlook TEE as a potential contributor or risk factor for post-cardiac surgery dysphagia. See if this is something that the patient had actually received. Okay, so to summarize, when you work with a patient who has extensive cardiac history and dysphagia, consider the following. Does this patient have a history of cardiothoracic surgery, and is it with or without TEE? The chest X-ray and chest CT, is there cardiomegaly? Is the heart enlarged? Does the patient experience dysphagia to solids? And does anything relieve that dysphagia? Remember that one case study where the gentleman felt a relief when he increased his dose to diuretic. So that was really important that they discovered that. Does the patient have fluid overload? Has a patient been admitted to the hospital in the past for fluid overload? This can exacerbate some things with swallowing and breath support and breath swallow coordination. And then understanding age and nutrition. So 70 plus, 80 plus years and malnutrition do increase the dysphagia risk in this population. So we really need to establish a strong relationship with cardiologists, cardiothoracic surgeons, nurses, everyone in the cardiac ICU or the cardiac surgery ICU. SLPs can play an important role in improving post-cardiothoracic surgery outcome, including length of stay and hospital costs, so much more, getting that diet started, everything. Now, not all cardiac-related dysphagia can be treated through our therapy. This is something to really consider. Sometimes, particularly with those mechanical dysphasias, there's not a whole lot that SLPs can do, but we can play an important role in identifying the underlying cause, and we can help speed up the appropriate referrals when patients come to us first with dysphagia complaints. So this is just something to be aware of. Now, I know I made it right to 9 o'clock and we have to stick to our schedule. So what I'm going to do is I'm going to check the Q&A and comments, and I promise I will get to all of you in the Q&A and comment section so that I can let our next wonderful presenter start speaking. So this will be Maurice. So I'm going to stop my screen share. All right, so Maurice, you are up next.
Hello, hello, hello. Let me get this shared here.
Yes.
Make sure the sound is on. Okay, should be good to go.
Woohoo, looks good. Take it away, Maurice.
Perfect, perfect, perfect. Well, my name is Maurice Goodwin, and I could not be more excited to be joining you this evening for the Spring 2021 MedSLP Collective Summit. Thank you to the presenters before me. Y'all were wonderful, Tiffany and Lauren, thank you. This is such an exciting night. Thanks to the collective for having me. I'm excited to be here and to talk about documenting the perceptual voice evaluation and practical applications in treatment of voice patients. So a little about myself. I am a full-time voice clinician currently practicing in Houston, Texas. My background is as a professional voice user myself, and I've been grateful for being a contributing kind of mentor to the collective for well over a year at this point. So this is exciting to watch things grow and more folks join us. So I want to give a quick shout out to my colleagues here in Houston, Dr. Apu Thekti, Dr. Yin Yu, Teresa Proctor, my speech pathology colleague and better half, and Margarita Rodriguez. I'm a better clinician because I work around those who strive for excellent patient care, and they push me to be my best and get my clinical documentation done absolutely as quickly as possible. So My disclosures, I do receive a salary from Houston Methodist Hospital, and I'm receiving an honorarium from the MedSLP Collective for this lecture. So what is the auditory perceptual voice evaluation? The amount of times that I'm about to say auditory perceptual, if this was a drinking game, I'd make it about 5 slides in. So it is a way of formally measuring the presence or absence of a voice disorder. And from there helps the clinician define and rate voice characteristics across a variety of voice tasks. Clinically, we hope this represents a documented, reliable, however subjective, analysis of a patient's voice at baseline, throughout treatment, and in short or long-term follow-up. So we do perceptual evaluations all the time. And by we, I mean every one of us. When we meet someone new, our brain is doing a ton of work to categorize and store their voice and voice quality. When we hear someone shout or yell, when we know someone is frustrated on the other end of a phone, these are all examples of kind of real-time applicable auditory perceptual evaluations. The difference between the general public and us as speech-language pathologists is that technically we are clinical experts in the function and physiology of the larynx, thereby the voice. So our standards for accurate clinical practice and documentation are significantly higher. So while I cannot speak for every voice clinic in the United States, I primarily work in outpatient care. So in our voice clinic, the auditory perceptual voice evaluation accompanies all other components of a clinical voice exam. So the article to the left has to be one of my most referenced articles regarding recommended instrumental assessment of the voice. It's an open access article through AJSLP for anyone, and I highly recommend those of you who are interested in kind of growing your work or kind of building a practice in voice and voice disorders to kind of take a look at this. And while the perceptual voice evaluation is a piece and it's documented in a very specific place in my documentation, it is something that exists throughout every part of the evaluation, and we'll kind of chat about that. So let's talk about the 2 major or main auditory perceptual evaluation tools that we most commonly practice with in the voice clinic. So some of y'all may have remembered 2 scales for documenting the auditory perceptual voice evaluation from your graduate voice disorders class and possibly never revisited them again. And while these rating parameters are not without their own limits, understanding their use and function within the assessment helps us to use them as tools. These tools help us gather information and kind of make some hypotheses and even kind of diagnostic decisions about what's happening with the larynx. So on the left, we have the Gerbis scale is kind of how I like to say it. This is a scale that I likely end up using most in my own clinical practice. It is easy, it is fast, it's pretty clear in my documentation, and it helps guide and focus my own ear and attention when working with patients. It's based on a rating scale of 0 to 3. So G stands for overall grade or kind of overall severity of the voice problem. Then we have roughness, breathiness, asthenia, or weakness, and strain. So on the right, you'll see kind of an example. If I had typed it out, I might say grade is 2, roughness, breathiness, 0, weakness, and strain are present. So Gerbis would be moderate dysphonia characterized by roughness, weakness, and strain. The 2 indicates, 0 indicates no dysphonia or normal voice quality. 1 would be mild, 2 moderate, 3 severe. And so this kind of shows you or gives you a visual and also perceptually like an anchor when listening and looking for the voice. And I know I'm going to do a kind of a brief overview of a lot because we're going to talk about a lot. So feel free to look these up later as they feel helpful for you. And then the CAPE-V was developed in partnership with the ASHA-SIG-3 group as a tool for use in the perceptual evaluation of voice. So this is a free rating form also available online. If you Google it, it's the first thing that comes up. And this is a tool that I also frequently use. The CAPE-V has both kind of a rating form and scale to use when making perceptions about voice, but it's also a set standard of stimuli using the rating form that includes sustained phonation, reading of the CAPE-V sentences. You can see those there. The blue spot is on the key again, etc., and also spontaneous speech. So I want to mention this. There are many words that we can and will likely use to describe the voice and voice function. We are not limited to like the 12 words that those 2 rating scales provide us. Many of us have kind of a vast, broad, patient-specific vocabulary that we work within. We have patients that have a specific vocabulary, or even the setting or our colleagues. Those kind of words and vocabulary and language, that matters too. And I'll bring this point up again, and I may slightly be calling out some folks watching this lecture, and it's not meant to offend, but just describing a voice as hoarse is not specific enough. And I know that's tough, and I know that in different settings, you're focused on different things, but describing a voice quality as hoarse is not enough. Saying that a voice quality is harsh tells me nothing about what is potentially happening at the level of the larynx and potentially going on with the vocal folds and other kind of laryngeal structures. So the perceptual voice evaluation is meant to kind of capture a lot of things. So we're looking at non-speech tasks like laughing, yawning, coughing, crying, singing. We are looking in a variety of contexts. So we're looking at sustained phonation, reading passages, and spontaneous speech. And then we're also looking for pitch and registry variety. So are things changing when someone's whispering, high pitch, a change of speed in their own voicing? Is there diplophonia or triplephonia present, or just instability or even tremor of voice? I think it's important to kind of specifically highlight maybe, well, one, non-speech, but also non-formal voicing. The auditory perceptual evaluation kind of turns on the minute that I meet a patient. And what do I mean by that? I mean, when I open up the door and say, hey, Mr. Smith, we're ready for you. From the minute that person says hello, or this parking lot was really difficult to find, or, you know, I've been waiting here for 30 minutes, the things that people usually say to me, I am listening to the quality and the presentation of their voice. All of those things matter and should be documented.
You ready?
Yeah.
Go ahead.
So, rainbow passage. When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch with its path high above and its 2 ends apparently beyond the horizon.
Okay.
So as we're listening to that voice quality, I'm going to play it just one more time. We're listening to the things that we're hearing. And there are maybe a few words kind of popping into your head. We can use either the Gerbis or the Cape V scales. I personally, throughout this lecture, will end up using Gerbis more than anything else. But I want you to think about what you are hearing. What are your ears hearing? And you can either jot that down or keep it stored up. I'm going to play this just one more time, and then we'll kind of talk about what we're hearing and where we're hearing it.
You ready?
Yeah.
Go ahead.
Rainbow passage. When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch with its path high above and its 2 ends apparently beyond the horizon.
Okay.
So after listening to that
You ready?
voice quality, what I tended to
Rainbow
rate the
passage.
patients, let me pause this. What I rated the patient's voice quality as moderate to severe dysphonia, characterized by roughness, weakness, and strain. And if you just look underneath here, certainly limited pitch range, kind of monotonous in quality, and we might call it like a vocal fry or a pulse register. It kind of sits at the bottom of the voice here. This patient's voice quality definitely had me scratching my own head, and kind of if we tie it with the history, which is also a part of the auditory, kind of everything that we do as a speech pathologist. There's a lot going on here. I'm going to play this just one more time while you're looking at what I rated this as. And it's important also to kind of bring this back. While these tools are meant to kind of formalize and bring this process together, this is subjective to an extent. This is what I am hearing based on my experience as a speech pathologist who sees voice disorders.
When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch with its path high above and its 2 ends apparently beyond the horizon.
While I was listening to the patient's voice quality, certainly I may have heard roughness and weakness, but the overwhelming quality in that patient's voice was strain. We should document that as such. I always find that giving your own kind of severity helps the clinicians or anyone else looking at your documentation kind of get a better handle on what's happening with the voice quality of the patient that you're seeing when we meet them. We'll get to kind of its application in treatment and in care in just a moment. Here's another kind of different voice quality. So we'll listen to this one first and then talk about how we might rate it in our own documentation.
Rainbow passage. When the sunlight strikes raindrops in the air. Sorry. They act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch with its path high above and its two ends apparently beyond the horizon.
Just say
E, E, E.
So this patient's voice quality, honestly, is probably not something that we haven't interacted with when we're kind of out in public. You might have heard like someone that's sick or someone, when people used to come to work with, colds and flus, this voice quality is probably not something completely unfamiliar. So let me move ahead and show you kind of what I rated this as.
Rainbow.
For me, once again, moderate to severe dysphonia characterized by roughness, breathiness, weakness, and strain when using the Gerbis scale. I also heard diplophonia and pitch breaks. So what the overwhelming quality that I am hearing is that sort of roughness, the instability in voicing there. Obviously there is breathiness there, weakness and strain. I want to play that again for you. And one reason why I think it's really important that we document correctly is that you can hear in the patient's voice, when she's talking, her voice is breaking up like this. So as we're listening to a patient's voice, we are trying to capture, what does this mean, right? What does that sound like? How do I put that into words? Because we don't always have access to recordings like this. More importantly, what does that voice quality tell us about the larynx? Well, we understand that vocal folds vibrate, and when vocal folds are working the way that vocal folds work, we get a smooth, consistent, non-dysphonic voice quality. Ooh. So if all of a sudden a patient comes into the clinic and their voice quality, ooh, more than just the quality of their voice, it's telling me something about how their larynx is or is not functioning. We are having a disruption of the vibratory characteristics of the vocal folds. That's an important thing to document. This is why this matters. It tells us, gives us information about the function of the larynx. We'll get into the fact that we don't have X-ray vision. And we'll talk about that in a moment, because I know some of you are like, but we can't see, and that's not a laryngeal exam. You are correct. All right, now here's the last one, and I think this one is super fun because what you'll hear the patient do is actually laugh and present with a completely different voice quality than when they're speaking. So we'll go into this next one.
Whenever you are ready.
Okay, ready to perform. When sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. The blue spot is on the key again. How hard did he hit him?
So certainly kind of overwhelming voice quality would be strain, right? We get this sort of tightness in the throat. And for those of you that treat voice disorders, our brains might be flashing and we're like, is this some sort of a spasmodic dysphonia? I want to play the laugh for you in the beginning, just so you can hear the contrast. This is the same speaker.
Whenever you are ready.
Okay, ready to perform.
Okay, ready to perform. When the sunlight strikes raindrops in the air. It's important as a speech pathologist that we are documenting. There are very different qualities being presented as the patient uses their voice. One in completely spontaneous speech when they're not thinking about it, when they're laughing, and one when we've asked them to read something. That is important to document. I think there's some other stuff here at the end I want to play just briefly.
And compared to the ha ha ha.
Okay.
This is
Ha 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 ha.
Good. Hoo.
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 You really get that ooh coming. Hoo. Ooh.
Hoo. Ooh.
Hoo. Hoo.
Hoo. Hoo.
Good. And now do. Mama made me mad.
Mama made me mad.
So we're hearing this kind of big difference between sustained phonation, hoo, 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 and then the minute the patient goes into a speech task where they're kind of copying the speech pathologist, mama made me mad. Those things are important to document. So overall,
Okay,
the quality
ready
that
to
I heard,
perform.
severe dysphonia characterized by primarily strain due to AD, adductor spasmodic dysphonia, like voice breaks and spasms in about 50% of all modal pitch tasks. The laugh was normal, strain was reduced on high pitched tasks, and the patient, based on their ability to produce smooth and clear voicing, appears stimulable for behavioral change, possibly. So, why does this matter? Why does it matter that our documentation kind of reflects what we're hearing in the clinic and in the evaluation? Once again, because writing hoarse for a patient's voice quality tells us nothing about the overall voice function. So now I don't, once again, mean to be controversial, because the reality is we also don't have like X-ray vision as speech pathologists. And similar to dysphagia, we are limited in our knowledge of a voice problem without proper instrumental evaluation. But an accurately documented auditory perceptual evaluation or diagnostic evaluation gives us an incredible amount of information about what's happening in the larynx. If a patient presenting with a weak, breathy, and frequently diplophonic voice quality following an ACDF procedure with abnormally elevated pitch for their age and gender, that potentially tells me a significant amount about what would need to be considered for further evaluation. This is not someone who just has hoarseness, and I, as a clinician, would be cautious to begin therapy with that voice presentation. So it's important that we're documenting what we're hearing and kind of building a case for what the patient might need based on that. Also, this is a great way for those of you that don't work alongside physicians to build a case for further evaluation, right? So if you see a patient, you're right, patient is hoarse and not stimulable for change. Well, what level of hoarseness? Because they could be mildly hoarse and somebody says, oh, well, I have mildly hoarse patients all the time. You should just do resonant voice therapy with them. But if a patient is severely dysphonic and not stimulable for change, then that is something that needs further instrumental evaluation. I am gonna repeat myself. I'm really happy I did not turn this into a drinking game. So what is the application in treatment? Well, there are a few. It helps kind of correlate what we're hearing with what we're seeing. There's a relationship to the patient's baseline, their improvement, and stimulability. So I just want to kind of break these down. Often, not always, what we're hearing in a voice quality correlates with what we can see. So the example that I just used of kind of like a weak, breathy, diplophonic, high-pitched voice is not something completely unfamiliar to a patient who may be diagnosed with like a vocal fold paralysis or a vocal fold paresis. I'm going to try and get one more voice quality in here since you guys are gassing me up on my ability to imitate voice disorders. And so that is that is something that's not unfamiliar to someone with a vocal fold paralysis. But there are patients with all sorts of disorders. I mean, I've heard patients that I was like, oh, for sure, they're completely functional. It's just MTD. We look inside their larynx and they have a big old polyp. Well, that patient may be recommended for, a procedure to remove the polyp with one of the laryngologists, and then they come for therapy. And so now my auditory perceptual evaluation is there and existing to help measure their improvement over time. So at session 1, they might be moderately dysphonic, characterized by like a weakness and a breathiness after the surgery that they've had. So it's not because the surgery wasn't successful, but there may be some stiffness of the tissue. The patient hasn't used their voice in 7 days. And so at that visit number 1, they're probably moderately breathy. And then visit number 2 and 3, we start to hear their voice get a little bit stronger. They are now mildly, breathy. And then by the 3rd or 4th visit, we are kind of rocking and rolling with a normal voice quality. The third part, stimulability. This is something that I use really regularly in the clinic. So when I meet any voice patient, I am listening to hear, are they stimulable for change in the quality of their voice? So when we are meeting with patients, when we're talking with patients, I spend at least the first 5 minutes of every session with every patient asking them about their families, their friends, what did they do over the weekend, how was parking, how was getting into the hospital. 1, because it helps to get to know the people that you're working with, but 2, my ears are on and I am listening to what their voice is producing. And so if a patient says, my voice is just strained and stressed all the time and I can't do anything, but then the minute I ask them to do this, hey, can you repeat after me and just sigh out? And they produce that quality. That tells me something about their ability for behavioral change. That should be documented. All right, so this is a good example. We're going to go
Rainbow
back to
passage.
Quality.
When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch with its path high above and its 2 ends apparently beyond the horizon.
Okay. So maybe no surprise to some of you listening, this patient was then diagnosed with adductor spasmodic dysphonia and was treated for voice therapy initially and then received Botox. And so this was the patient's 2-week follow-up.
Early one morning, a man and woman were ambling along a 1-mile lane running near Rainy Island Avenue. He saw half a shape mystically cross 50 or 60 steps in front of his sister Kathy's house. Albert eats eggs every Easter early in the a.m. When he comes home, we'll find him. We mow our lawn all year. Harry had a whole half-pound hamburger. We rode along Rhode Island Avenue. She sells seashells by the sea.
So if all I wrote in my documentation was better voice, once again, that doesn't tell me much about what's happening after the patient received a pretty significant treatment and something that impacts their larynx. But documenting a kind of a moderate to severe to then mild voice quality gives me a pretty clinically significant change in voice that can then be measured. Let's say this patient then presents with a mild voice quality on week 2, but then by week 4 or 5, they're back in the clinic and they're about moderate, and you can start to hear some of those pitch breaks again and some of the strain. Documenting the voice quality over different time points tells us, is this treatment successful? Do they need to be referred back to the laryngologist? Is there something else going on that we are not catching? But saying good or bad or hoarse or better, it's just not adequate enough to gather the information that we need to make the best, the most accurate, the best for the patient clinical decision. So what would I be and who would we be as the MedSLP Collective if we did not recommend further resources for y'all to have some training in this? The Perceptual Voice Qualities Database is an auditory perceptual rating training tool funded by the Voice Foundation's Advancing Scientific Voice Research Grant. The voice samples included are rated by voice professionals using the Gerbis and Kate V rating scales and include 296 audio files consisting of the CAPE-V stimuli previously mentioned. And this can be found, I'm going to include the links here in the Zoom chat in just a moment, by Googling the Perceptual Voice Qualities Database and on the Voice Foundation's website. And another resource for practicing kind of your own training, auditory perceptual training, would be the resource offered through the University of Wisconsin Voice Disorders Simulations. The scoring rubric is based on the CAPE-V rating scale. The participants are split into 9 different simulation groups with different themes of voice quality. This is an incredible free resource. Both of these are offered to folks spearheaded by Dr. Nadine Connor and the University of Wisconsin Resources for Teaching and Learning. So let me include these links here. Let me copy and paste. Wonderful. So hopefully this goes out to everyone. We should get this here. And then I'm happy if there are any questions to answer anything. Obviously, you can find me on Instagram at Maurice_Goodwin, here on Facebook. And then also at my work email at mgoodwin@houstonmethodist.org. Happy to answer any questions that y'all have.
Woohoo! Oh my gosh, awesome presentation, Maurice. We do have some questions here. Let's see. So regarding voice therapy, we've been told for years not to treat without an ENT consult. What do you recommend when the patient lives in a SNF and the consult is not always followed through? Are we not allowed to treat?
Yeah, I think that's tough. I think, I don't know that you're not allowed to treat. I think as long as there is a diagnosis of dysphonia as made by, I think even like a PCP can diagnose, dysphonia, and technically under insurance rules, you're allowed to treat then, as that is a diagnosis that we cover. I have to admit that I have an extremely I'm super privileged in the work that I do, so I work alongside physicians, but I have been in a position where I've had to treat patients without laryngeal exams, and it's never been a great situation. Maybe 1 or 2 in years now that I've been doing this, that has worked well for me. And I know similar to instrumental swallow evaluations, it can be tough, but I think if we build the case, certainly in the collective, we talk about this a lot. So if you join the collective and are able to kind of check and see the questions people are asking about voice, these are the questions they're asking. And we kind of dig into this together as mentors and as a group. But certainly, we typically no harm in things like SOVT exercises and resonant voice. It totally depends on the disorder and what you're hearing though. So using your ears and your clinical judgments, we try and make the best decisions possible. That's a tough one.
Yeah. All right. Thank you. We got another question here. Could you please describe the quality of asthenia a little more and its clinical markers?
So asthenia is a little difficult for me. It's not something that I like hang my hat on a ton. I will just say like a generalized weakness. And often it's hard to kind of differentiate perceptually weakness and breathiness because often they kind of share, they tend to be neighbors of each other, but I certainly have patients that may be breathy and strained. So their voice quality sounds like this, and the patient isn't necessarily weak. I can hear them, but their voice is definitely breathy, right? And then you have patients who maybe talk like this. I can maybe think of like a patient with Parkinson's who just has kind of a low phlonia or a kind of a not low phlonia, kind of a weak voice quality, then I would use asthenia in that situation.
Awesome. Thank you so much, Maurice. I know it is 9:30, so we will move on. All right. So we have our next presenters here. We have Kahla Graham and Amanda Weissberg, and they are going to discuss the multidisciplinary management of tracheostomies. So Kahla and Amanda, I'm gonna let you all take it away.
Great, thank you. Just get this set up. Okay, great. So Today, we will be discussing multidisciplinary management of tracheostomies and creating a collaborative approach to care across medical settings. So my name is Kahla Graham. I'm a speech language pathologist and a board certified specialist in swallowing and swallowing disorders. I work within the acute care setting at a large academic medical institution in Chicago. My professional experience and my clinical interest involve working with patients with neurodegenerative diseases, pulmonary diseases, and acute respiratory illness. And I work closely with our team of pulmonologists and respiratory therapists to provide care to patients with tracheostomies.
And my name is Amanda Weissberg. I am an acute care speech pathologist in Los Angeles, soon to be Dallas in 2 weeks. I have also worked across a continuum of medical settings, including outpatient, skilled nursing facility or SNF, subacute, inpatient rehab, and of course, acute care. So both Kahla and I receive an honorarium for this presentation and are medical SLP collective members and affiliates, and we have no other non-financial disclosures. So the objectives, so after participating in today's presentation, viewers will be able to describe 2 potential benefits of a tracheostomy team for any setting, and list 3 interdisciplinary members of a collaborative tracheostomy team and discuss considerations for developing a trach team across different settings. So as we begin, you're probably asking yourself, Amanda, Kahla, what is a multidisciplinary tracheostomy team? So this is a group of professionals from distinct disciplines that collaborate to improve patient care and outcomes. This can include development and implementation of standardized protocols or procedures, streamlined communication, and interdisciplinary management. It is unfortunately a system that is not implemented in every institution, but we're here to show you what it can look like, possibly formally and informally as well. So across the disciplines with tracheostomy care teams, the members and roles of a trach team vary amongst institutions and level of care, but the members of the trach teams can look different but usually have a consistency to them. So for instance, they may include the physician or surgeon, respiratory therapist or RT, speech language pathologist, SLPs, mid-level providers such as, nurse practitioners, clinical nurse specialists, nursing staff, social workers, registered dietitian, and more, depending on your team. And each member plays a valuable role to bring a certain skill set to the team, although the 3 key members to a trach team, according to the literature, are going to be the physician champion, the RT, and the SLP to provide that patient-centered care.
So research has shown that multidisciplinary tracheostomy teams in this coordinated care can decrease time to decannulation or removal of the tracheostomy tube, decreased length of stay, the number of adverse medical events, and cost of admission. It can also increase speaking valve use for communication and quality of life.
Open instrumental.
So while some organizations may be able to support a formal or an established multidisciplinary tracheostomy team, we understand that this is not feasible at all facilities or across all settings. But what is feasible is establishing a relationship with other disciplines to provide the best patient care. So we created this visual to demonstrate what we will refer to as either informal or informal multidisciplinary care teams to discuss how they're similar and how they're different. So a formal tracheostomy team might be recognized by the organization and function as one unit. They might have set frequencies and modes of communications and follow set protocols and procedures to evaluate the patient, monitor for progress, and advance them. An informal team in comparison may not have set protocols or meeting frequency, but the involved disciplines have a direct line of communication and guidelines to help them determine patient care pathways. So where these teams overlap in general are the goals of multidisciplinary care, to collaborate with other team members to support the patient, to improve patient outcomes such as communication, swallowing, quality of life, possible decannulation, and to ensure that the patient is receiving adequate care and education every step of the way. Here are some examples of procedures that can be standardized, developed, evaluated, and implemented by a collaborative care team in any setting. Starting off with training and education for staff working with patients with tracheostomies. So the speech pathologist, respiratory therapist, nurses, physicians, anyone who is directly involved in patient care. Steps for completing a PMV evaluation, downsizing, capping, and decannulation, candidacy and steps, tracheostomy care, and patient education. Here's a visual example of an algorithm that was developed by a multidisciplinary care team in an acute care setting to help healthcare providers determine candidacy for a PMV evaluation. So while the steps may look different across levels of care or at specific institutions, tools like these can provide consistent care for patients and improve patient outcomes.
So to further highlight the role of these multidisciplinary care and how this differs across the setting, we thought we would present a case study and follow a patient across 3 levels of care to kind of put all these puzzle pieces together. Our patient's name is Tom. So Tom is a 73-year-old male with a past medical history of chronic obstructive pulmonary disease, or COPD, and diabetes type 2. He presented to the hospital with shortness of breath and was found to have a resting oxygen saturation of only 70%, tested positive for COVID-19 with the subsequent pneumonia. Tom was then intubated in the ICU and had a prolonged mechanical ventilation course over 15 days due to acute respiratory distress syndrome. Tom unfortunately failed multiple spontaneous breathing trials in attempt to wean from the vent and underwent a tracheostomy with a placement of a Shiley 8 cuff trach. So we are going to start off with Tom in acute care. So at the level of acute care, this multidisciplinary tracheostomy team operates in a formal unit at this particular hospital that we are mimicking here. So they have established protocols, procedures, frequency of communication, and the primary goals for Tom at this level of care include weaning from the vent, evaluating tolerance of a speaking valve, evaluating his swallowing function, and providing therapy to optimize his functional status. The trach team in this example consists of pulmonologists, the physician's assistant or PA working under a pulmonologist, SLP, and a tracheostomy specialist from respiratory care department. When the tracheostomy was placed, a bundled order set was then entered into the medical record system to bring about those appropriate evaluations by the team members listed, notify the nurses of daily care requirements, and implement weekly rounding of their team. The team followed the organization's standardized protocol for vent weaning, starting with spontaneous breathing trials, or SBT. After multiple failed attempts, the patient was placed on pressure support mode of ventilation. The team then continues to address these goals by completing SBT once per shift. And when the patient reached the organization's criteria for conducting a PMV evaluation on the vent, then the evaluation was completed. And this team used the established references by the criteria from PASI-MIR. Upon deflation of the trach for the cuff by the RT, there was no change in tidal volume or evidence of airflow through the upper airway, suggesting reduced upper airway patency. And the patient was determined to not be a candidate for PMV placement at the time of this initial evaluation. And then it was recommended to the team that the tracheostomy be downsized in order to facilitate that upper airway patency, or openness of the airway to allow the air to pass superiorly through the larynx. So then for his swallowing, a fiber optic endoscopic evaluation of swallowing, or FEES, was also completed per their protocol. So this demonstrated oropharyngeal dysphagia, and the patient was then recommended a modified diet and therapy to rehabilitate swallowing function that appeared to be weakened due to the critical illness myopathy. So now Tom is going to be moving on. So now we're going to see this case study continue in a long-term acute care settings, or an LTAC. So Tom was discharged from the acute care to the LTAC. And at the time of admission to the LTAC, the patient was on a pressure support mode with a Shiley 8 cuff trach, communicating, mouthing words, and pointing to items on the communication board, consuming a modified diet. And you'll see here, although there's not this formal trach team that we saw in the acute care setting, in this setting, we're going to see more of this informal approach where team members monitor the patient's progress, they communicate frequently, and provide recommendations to advocate for the patient and improve the outcomes. So here's a great example of more of an informal multidisciplinary team prioritizing still that patient-centered and timely intervention. So let's go to the goals. Some of the goals of this level of care are carried over from acute care hospital setting, such as weaning from the vent, downsizing his trach, continuing that dysphagia treatment, initiating the speaking valve, all when appropriate. The disciplines involved in addressing these goals are still going to be the RT, SLP, the nurse, and the attending physician when available. And in this setting, the nurse provides daily tracheostomy care, and the patient is followed by speech and RT about 3 to 5 times a week. And the way that this team communicates is by paging. So the initial evaluation of the patient by physician, RT, and SLP yielded recommendations for the patient's tracheostomy tube to be downsized upon admission. So you can see here, it's happening in a timely process. This was determined by medical stability on the vent, and frequent need for suctioning, and no known history of upper airway obstruction or anything else, requiring a different trach size. So the tracheostomy tube was later exchanged for a cuffless trach. And then we're going on to continuing that weaning of the mechanical ventilation, again, determined by multidisciplinary communication and collaboration. The patient continued to participate in dysphagia therapy with speech about 3 times a week. And a repeat video swallow study was conducted when the patient began tolerating more trials on the trach collar or supplemental oxygen without ventilation. The video revealed improved swallowing kinematics and no aspiration of liquids when the patient was weaning with a PMV. The SLP continued to follow for therapy and training of swallow precautions, strategies, including importance of wearing the PMV during the oral intake. And you can see here why this multidisciplinary connection and communication would be important for that, because when we're evaluating the patient under a circumstance and then recommending it that way, it's important for the full team to have that open dialogue, communication, and consistency and training. Also, the vent weaning was continued, and the patient was seen for co-treatments with the SLP and RT for respiratory muscle strength training using both inspiratory and expiratory muscle strength training devices. Again, that collaborative care between 2 different professions. And then Tom was successfully weaned from mechanical ventilation prior to discharge. So without this collaboration amongst the speech pathologist, the RT, the doctor, and this frequent follow-up with the nursing, the patient may not have undergone downsizing or had access to communication, or maybe yielded off of that vent as soon as he did. So you can see here all the benefits that even an informal trach team can have.
Great, so we're going to follow Tom to the last setting in this example, which is an outpatient setting. I know that there are certain scenarios where speech pathologists may work under or within a clinic of otolaryngologists or ENTs, and so maybe there are certain outpatient settings where this collaborative approach is conveniently within office. However, this is often not the case in outpatient care or even home health settings where you have all of the team members present at all of the time. So in this example, this is an outpatient setting where the physicians are not located in the current office. So the patient was discharged home from the LTAC or long-term acute care with the support of his family, and is referred to the speech language pathologist for an outpatient clinical swallow evaluation by the patient's primary care physician. So in this setting, multidisciplinary care is again informal, but the goals are to promote independent tracheostomy care, decannulation, and safe swallowing. So the team members in this setting include the PCP or the patient's primary physician, the speech language pathologist, and then an ENT who is later consulted as part of this collaborative care approach. So the patient was seen for a clinical swallow evaluation in the outpatient setting. He reports consuming a general diet with thin liquids and wears his PMV during all waking hours. He reports that his primary goal is to have the tracheostomy tube removed. So the speech language pathologist was able to gain access of the most recent video swallow study that was conducted and was able to read and interpret that report. So the clinical swallow evaluation completed appeared consistent with the documented swallow physiology described on the recent exam. So the speech pathologist recommended that the patient continue his current diet, wear the PMV during oral intake as he had, and just reviewed those results with the patient and his family. So both the speech pathologist and the patient's primary physician individually reviewed basic tracheostomy care, such as caring for the tracheostomy, the stoma, cleaning the inner cannula, and the PMV. Given that the patient and the family report that the patient wears the PMV during all hours through the day, does not have respiratory distress, need for suctioning or supplemental oxygen, and is relatively independent in tracheostomy care, the speech pathologist conducted a call with the primary care physician and a consulting ENT to discuss the appropriateness for capping trials and possible decannulation. So after this phone conference, the patient was then seen by an ENT for assessment, and the patient was deemed appropriate for capping trials supervised by his family. So although the team members were not all in the same location, they worked collaboratively to address the patient's goals, progress the patient, and ultimately promote patient safety. So now that we've talked through a case example and provided examples of how collaborative care can operate across settings, we want to discuss the steps to achieve this collaborative care approach. So start by reviewing the research and evaluating the current needs of your setting or your organization. Consider creating an outline to support your initiative and brainstorm with colleagues or other disciplines who would be involved. Discuss the barriers and needs identified by each key discipline, the goals, and the structure of how collaborative care can be provided. So we've given you a few examples of how this team, a team could operate across settings as either this formal or informal unit, depending on what works best for your setting. Gain support from your department and your organization's leadership. Evaluate existing policies, procedures, guidelines, or patient care pathways, and ensure that all disciplines provide their input and are in agreement with recommendations. So this can include emergency procedures, evaluations, and different protocols or guidelines. Once these guidelines are established, make sure to educate medical staff on the changes to practice patterns to ensure consistency of care. And lastly, consider how your individual team will monitor progress following implementation of this collaborative care approach. So maybe you want to consider doing this as a process improvement project within your institution so you can track the change, or maybe this is going to be more internal and anecdotal, looking at how these communication and connections change across time.
So to wrap up this presentation, we did want to highlight some, considerations because, ultimately this isn't going to necessarily be something that happens overnight, but what we definitely wanted to demonstrate was that it can evolve through an informal way as well. So just because it's not automatically going to a formal setting or a formal pathway or, objectives or procedures, it doesn't matter that those informal measures, cannot be made as well. So in order to do this, multidisciplinary care improves these patient outcomes. And we know this, and it can be achieved across the settings. And regardless of the setting, it's going to require networking, advocating, persistence to achieve this. And these standardized procedures can help to streamline patient care. And we must remember that care is to be patient-centered and will vary depending on the patient and their specific needs as well. But having these guidelines and procedures in place will allow for more consistent, safe, and timely care in this way. And I think more than ever, we've seen it this year through COVID, because COVID-19 has had an immense impact on, these tracheostomy practice patterns and needing that consistency throughout care.
Yeah, I agree, Amanda. I think COVID has changed a lot when it comes to tracheostomies, regardless of the setting that you're in. And I anticipate that we'll continue to see ongoing sequela of events and changes related to the COVID pandemic. So with so many patients having prolonged intubations or multiple intubations when they're hospitalized for severe COVID, we may see secondary complications such as laryngeal dysfunction or tracheal stenosis. And these secondary complications could impact tracheostomy practice patterns, such as when a tracheostomy tube is placed or what type of tracheostomy tube is placed, how we determine candidacy for decannulation or downsizing, and ultimately discharging plans. So, we might see patients discharging home more frequently with tracheostomy tubes. And I think it's important that we are all collaborating and that we're all establishing these pathways to promote patient safety and success. Education and clinical training are essential when working with these with patients with tracheostomy. So, and I know Amanda and I are both fortunate to have worked in settings where we did receive great education and supervision and training of how to work with patients with tracheostomies, but that's not always the case. So, whether you've had limited training or experience working with patients, maybe you don't see patients with tracheostomies as frequently, make sure that you are advocating for yourself and that you're staying up to date on clinical practices and seeking resources to learn more. So you could consider, reaching out to other SLPs in your area or SLPs through the MedSLP Collective or ASHA or your state organization to bounce ideas off of, gain support from clinician to clinician. And there are also numerous resources available online for further training related to caring for patients with tracheostomy. So some of these include webinars and resources that are available through the MedSLP Collective, the Global Tracheostomy Initiative, Casimir, and some of the other sites listed here.
And I think something too is, so part of the collective, Kahla and I both actually have a 3-part series. I believe the first part was already set out for resources, but about these trach teams as well. So a little plug for our work, but I think especially, and through COVID, even smaller hospitals that I've been a part of, suddenly when they didn't have really any tracheostomy or vent patients, all of a sudden it was all ICU. So bringing in even Casimir, having that in service, having these different professions sit down and all hear the same things, that is also your first step to creating this team dynamic. And like we said, whether it's formal or not, if you all have that same groundwork of education or what is expected, then you can see those improved patient outcomes as well.
So if you have any questions or comments about anything that we presented on, feel free to contact us. Both of our emails and our Instagram handles are here. Amanda already told you, but we helped to create the tracheostomy team resources through the MedSLP Collective. So if you're interested in this topic and want to learn more, check out those resources. And we do have references here if you want to go back and look at some of these and kind of add them to your resource library for this population. We have some references for you. Thank you.
Yeah, thank you so much. And I think we have a few minutes for some questions too.
Yes, thank you both so much for this amazing presentation. We do have several questions that have come in. The first one, Kahla, well, and Amanda, I think you both actually touched on this. It was, can you recommend an in-service or resource that outlines the very basics of trach education for SLPs? So was there anything else you wanted to add on top of what else you guys had just mentioned about that?
I don't. I think I'll go back to that slide too, just so you can look at them again. But I would start kind of here in this list with, you know, the resources available on the collective. The Global Tracheostomy Initiative it has resources for clinicians, but also for patients and their family. So I often refer patients to this website so that they can kind of investigate and do some learning at home and then come back with more specific questions. And also Passimir, they have great educational resources that are free. So very basic tracheostomy education all the way to ventilator specifics and doing inline speaking valve evaluations.
And also, you don't have to always reinvent the wheel either. You know, if you're part of a system that has neighboring facilities or sister hospitals, sister, you know, skilled nursing facilities even, you know, you can lean on those other SLPs or teams or physicians to adapt that into your own system as well. So, and then also through the collective, you know, is a great way to pick other people's brains. And like I said, not reinventing the wheel is the main goal sometimes, but it will take time. And I think patience is key, but that's why we kind of just wanted to shine light on that. Even when that is taking time, these informal ways can really great benefit.
Awesome, 100%. Thank you. And real quick, before I continue the questions, I'm going to repost it in the chat for all the Zoom members. I'm just copying and pasting what Teresa had put in. So make sure to click on this link tonight for your attendance for these webinars. So I just wanted to put that out there. And I need to mention really quickly that the ASHA CEUs are still available in the Medical SLP Collective. If people that are watching here for free, you can go to medslpcollective.com/summit upgrade. I will put that in the chat. So just wanted to let you all know before we continue on with the questions here. All right, so next one, let's see. Oh, we got part 2. So should a SNF ever accept a patient with a trach if they do not have an RT on staff?
Amanda, I'm going to let you take this question because you have experience in the SNF, but I can follow up too. And
yeah, I would not feel safe with that option. I have been in skilled nursing facilities with trach patients, but they have RTs readily available outside the room at all times. I can't imagine if there was something, you know, if there was like a decline or something and an RT wasn't there, because primarily we're working with them for even things like mucus plugs or downsizing or capping. And, you know, it would be an interesting situation without an RT, I would say.
And I think every facility is different. And I know that a lot of times at some of these places, there might be a respiratory therapist who is hired there, but isn't there all of the time. And so I think it really depends on the level of care that this patient requires. Why do they have a tracheostomy tube? When was it placed? And how often will the respiratory therapist be involved? And are the staff trained in emergency procedures? So if the respiratory therapist isn't there, do the physicians, the nurses, the speech pathologists know what to do in an emergency and how to handle that? And I think if that answer is no, then I would be hesitant as well and want to make sure that the patient's going to be safe.